hypotensive and you have to add on drugs to push their blood pressure up, such as inotropes to make their heart squeeze more, or vasopressors to squeeze their blood vessels, because if you squeeze the blood vessels, your resistance goes up. And if what is blood pressure equal to? Cardiac output times resistance. So if resistance goes up, blood pressure goes up. If you're using these drugs to try to maintain a good blood pressure, you're in shock. And that's a concerning finding. Another thing that concerns me of shock is if they're hypotensive on these medications plus their lactate's elevated, because it means I'm not using their organs appropriately. And even worse than that, if I have a high lactate, hypotension recording pressors, and I'm having to compensate and squeeze my vessels and vasoconstrict them, that my extremities are becoming cold, pale, mottled, that means my resistance is way too high and I'm in a shock state. If I have hypotension, if I have altered mental status, angina, hypoxia or dyspnea, or worst case scenario, full-blown cardiogenic shock, that's an indicator of instability in that setting. Okay. The next complication, the most terrifying, is cardiac arrest. And this can be seen in 4 different types, but we'll go through this in the sense that the patient is an abnormal activity, they're not generating a good enough cardiac output. And actually, I would say they're not generating cardiac output at all. Therefore, if they're not getting blood out of their heart into their actual circulation, they're not generating blood pressure. If you're not generating the blood pressure, if I go to feel their radial pulse, I won't feel one. So they don't have a pulse. Therefore, they're not perfusing organs. And if they're not perfusing organs, we are now considering this patient to be in cardiac arrest. The type of cardiac arrest that they are in depends upon the type of rhythm that they're in. So are they in PDA arrest, meaning that they have an organized rhythm on their ECG, so it's like normal sinus, but they don't have a pulse? That's PDA. Do they have a flat line and then no pulse? That's asystole. These are non-shock rhythms. In other words, you don't defibrillate these patients. You just do compressions and give them epi. And the other scenario, do they have VTAC? Do they have a wide type of regular tachycardia? That's concerning for ventricular tachycardia, and that right there is a shockable rhythm. And then lastly, do they have this wide irregular rhythm that's consistent with VFib? That's also shockable. So these are shockable. This is not shockable. The question that you have to ask for these patients is, what drove their cardiac arrest? Why did they go from having an arrhythmia to having pretty much no blood pressure, no pulse? And you want to remember these based upon the ease of them, especially during a code, which is the H's and T's. So as the patient is undergoing the CPR process, you want to be evaluating the underlying cause. Could it be due to hypoxia? Could it be due to hypotension that they're having this? Could it be due to severe acidosis? Could it be due to hypo or hyperkalemia that's causing this? Could it be due to hypothermia? Could it be due to tamponade, which is causing an obstructive shock? Tension in the thorax causing an obstructive shock? Is it a thrombus, which is in the myocardial kind of area, the coronary vessels, so an MI, causing cardiogenic shock? Is it a PE, causing obstructive shock and severe hypoxemia? Or is it toxins that are driving this process? The reason why it's important to know this is that if you kind of treat these, you may prevent them from either going back into cardiac arrest or take them out of cardiac arrest. Give them oxygen, increase their blood pressure. Give them volume, give them vasopressors, give them bicarb, give them potassium, give them calcium, and get rid of the excess potassium. Warm them up. Do a pericardiocentesis, do a chest tube, give them TPA, give them PPA, reverse the toxin if possible. That's the concept of why this is important. All right, my friends, now let's talk about the diagnostic approach to bradyarrhythmias. So for these patients, if they're coming in, they're bradycardic, heart rate less than 60, preferably islet less than 50, then the first thing you need to do is obtain an ECG. The reason why this is going to tell you if it's a sinus bradycardia or an AV block, and then we're going to go through the different types of AV blocks. I'm excited to show you guys this. So, first things first, when you look at the ECG, you have to ask 3 questions. Is there a sinus rhythm? In other words, if I look at this ECG here, is the P wave uprightly to an inverted AVR? If it is, that's kind of indicative of at least sinus rhythm. Next thing, if I look at these and I go after the rhythm strip and I look at every single component, after every P wave, is there a QRS complex? If there is, okay, it's still potentially sinus bradycardia. The last thing I have to make it sinus bradycardia is I have to have a normal PR interval, meaning the distance from the beginning, right before the upward deflection to the point where I have my downward deflection for the Q wave and the QRS complex. I have to have this between 160 to 200 milliseconds, which is usually less than one big box. to look at these and kind of go through this. So the first one is the PR interval prolonged, meaning it's greater than one big box. So if I zoom in on it, is this greater than one big box? And it 100% is. It's greater than 200 milliseconds. So therefore, I have an AD block. I just have to ask myself the question. In order for it to be a first degree, you can't drop the QRS. It's just a prolonged PR interval. Do I drop any QRSs here? No. That's first degree. Is my PR interval getting, when I zoom in here, longer and longer and longer? Then do I drop the QRS complex? Because if I do, that's a second degree Movitz 1. So it's longer drop, you have leaky lock, right? The next thing is if I zoom in here on my rhythm strip, is the PR interval constant, but then I just randomly drop a QRS complex here after that P wave. If that's the case, that's a second degree Movitz 2. And then lastly is if just like I look at this thing and there's like a ton of P waves and then there's a bunch of QRS complexes that are usually maybe wide, meaning it's an infranodal block, or I just see a bunch of P